Hello, my name is Nevaeh Oxt, and I chose to do my final diagnostic presentation on obsessive compulsive disorder, also known as OCD, in children. Some background information on OCD is that it can affect children by causing functional impairment and can affect one's family/social life and their academic performance. OCD tends to be chronic, and a substantial number of patients still struggle with OCD symptoms in adulthood. 30 to 50% of adults with OCD report symptom onset in childhood, and the World Health Organization ranks OCD as being among the 10 most debilitating disorders. Let's begin with an overview of the DSM-5-TR diagnostic criteria for the condition. I'd like to note that the diagnostic criteria is the same for adults as it is for children. There are 4 categories that must be met for the condition. Category A being the presence of obsessions, compulsions, or both, and the DSM-5-TR defines obsessions by 1 and 2. 1 being recurrent and persistent thoughts, urges, or images that are experienced at some time during the disturbance as intrusive and unwanted, and that in most individuals cause marked anxiety or distress. And 2 is defined as the individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action. An example of this would be by performing a compulsion. While compulsions are defined as 1 and 2, 1 being repetitive behaviors. Examples of this include hand washing, ordering, this means arranging things in a specific order, checking, an example of this would be checking to make sure the door is locked repeatedly, or mental acts. Examples of this include praying, counting, or repeating words silently. The individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. While 2 is defined as the behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or they are clearly excessive. The DSM highlights a note in the diagnostic criteria that states, young children may not be able to articulate the aims of these behaviors or mental acts, and this is really one of the only distinctions we see be made between adults and children. Criteria B is the obsessions or compulsions are time-consuming. For example, they take more than 1 hour per day or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. While criteria C is the obsessive-compulsive symptoms are not attributable to the physiological effects of a substance, for example, a drug of abuse or a medication, or another medical condition. Finally, criteria D, the disturbance is not better explained by the symptoms of another mental disorder. I would also like to point out that the DSM lists 4 categories that you should specify if the patient has. Specify if with good or fair insight. This means that the individual recognizes the OCD beliefs are definitely or probably not true, or that they may or may not be true. While with poor insight means that the individual thinks OCD beliefs are probably true, while with absent insight/delusional beliefs, it means that the individual is completely convinced that the OCD beliefs are true. This categorization allows for licensed professionals to ensure that they are choosing the best route for possible treatment options. This is because a person with good or fair insight may react far better to certain treatment options, such as psychotherapy, compared to an individual with absent insight/delusional beliefs. In the last category, the DSM would like to be specified is tic-related. Tic-related means the individual has a current or past history of a tic disorder. The reason behind this is due to an individual having a tic disorder would also influence the course of treatment. Up to 30% of individuals with OCD have a lifetime tic disorder. This is most common in men with onset of OCD in childhood. People that have a history of tic disorders and a diagnosis of OCD differ from those with only OCD by their symptoms, comorbidity, course, and pattern of familial transmission. I'd also like to mention how it is possible to see a triad of OCD, tic disorder, and ADHD in children, and the DSM also highlights this. Now that we have delved further into OCD and what it entails for an individual, let's look at some of the current literature and research that has been conducted in the past 1 to 3 years, specifically regarding pediatric patients. I'd like to note the lack of recent research There are not that many options, unfortunately, that were very recent. However, I do think the following articles obtain some interesting and important information. The first study that I would like to touch on is a 2023 study titled The Efficacy of ERP on Perfectionism as a Symptom Cluster of OCD in Children. This article is looking at different forms of OCD. The study labels these different forms as symptom clusters. Some of these symptom clusters include contamination, sexual obsessions, perfectionism, and so on. The study states how the quote-unquote golden standard of treatment for these symptom clusters is exposure and response prevention, also known as ERP. The researchers touch on how there is little to no previous research conducted on ERP treatment in the various symptom clusters of OCD. So this study was developed using a quantitative research design to see how ERP influences perfectionism OCD compared to non-perfectionism anxiety when predicting treatment outcomes in children. They wanted to better understand which type of OCD symptom clusters impacts treatment outcomes for either for better or for worse. This way that there would be significant improvement in treatment outcomes for children with OCD. First, let's begin by looking at the research question they asked in the study. Their exact question was, to what extent does ERP influence perfectionism OCD compared to non-perfectionism anxiety when predicting treatment outcomes in children? And their hypothesis was the following. Perfectionism does impact ERP. Individuals with perfectionism as an OCD symptom cluster will show less resistance to ERP treatment compared to individuals with non-perfectionism anxiety. Perfectionism responds better to ERP than non-perfectionism. The data in the study was analyzed from the Multi-Dimensional Anxiety Scale for Children, which is known as MASC, and this was used to measure the participants' anxiety and symptoms of OCD that load onto perfectionism. And this was done by using a Likert scale where participants answered questions based on how true the statement was for them. And this was done on a 4-point scale. So, for example, 0 would be never true about me, and 3 is often true about me. In total, there were 146 participants included in the study that ranged from ages 7 to 17, and I would briefly like to touch on the inclusion criteria for the study. Participants must have a primary diagnosis of OCD assessed by the Schedule for Affective Disorders and Schizophrenia for School-Aged Children, present and lifetime version. Present meaning symptoms right now or recently in the past, and lifetime meaning symptoms at any point in their life. A score of at least 16 on the Children's Yellow-Brown Obsessive Compulsive Scale, and an IQ test of at least 85. Now let's move on to the treatment. Firstly, the study states that the treatment outcome analyses were conducted with all participants who were randomized. Participants engaged in 10 sessions of family-based CBT. The first 3 sessions focused on psychoeducation, hierarchy development, and cognitive interventions, while sessions 4 through 10 focused on ERP. Before the first exposure session, children who continued to meet criteria for OCD were randomized in a double-blind fashion to receive either weight-adjusted D-cycloserine, also known as DCS, or placebo, along with exposure therapy for the remainder of the treatment. DCS is an antibiotic that is used to treat tuberculosis. However, it has also been recently used to enhance exposure-based treatment for anxiety. The medication seems to be promising, however, its effectiveness has not been fully established yet. The study had significant results. Exposure therapy led up to an 80% difference on the perfectionism item of the MASC, compared with up to a 73% on the non-perfectionism items. This is a large difference, meaning that there is a greater change after exposure therapy in perfectionism compared to non-perfectionism items. This shows how different symptom clusters can benefit from different forms of treatment. Regarding perfectionism before exposure therapy, which is time 1, the perfectionism scores only predicted 20% of the perfectionism levels at time 2 after exposure, meaning that 80% of perfectionism after exposure is due to something that happened during the exposure therapy. However, the study states that they do not truly believe that the 80% of perfectionism at time 2 is only a direct cause of exposure therapy, but rather that more change in perfectionism was explained by treatment with exposure compared to the effect of exposure on non-perfectionism. With this information, we can see that certain forms of treatment can produce better outcomes for children with different cluster symptoms of OCD. The study states that further research should examine different symptom clusters of OCD compared to how their ERP treatment outcomes vary, and I completely agree. Further research could provide significant improvement to children with OCD. With further research on different symptom clusters and ERP treatment, it could allow clinicians to apply effective treatment to specific symptomatology, giving the child the exact care that they need, thus reducing stress levels during treatment and providing overall more effective care. Further research could also become an early indicator of children who may struggle more with ERP due to their specific symptoms. If this were to be identified and established, these children could receive extra support and care in their treatment process to provide the best possible treatment experiences for them. Moving on to the second study. This study was published this year and is titled Coexistence of Capgras Syndrome and OCD in Children, Case Studies. The study is analyzing the co-occurrence of Capgras syndrome, also known as CS, and OCD in children. First, the study begins by stating that CS is characterized by the delusional belief that a person, usually a close relative, has been emplaced by an imposter. It is common that children with CS identify their parents as imposters. This is a rare mental condition that is typically seen in adults with schizophrenia, making it very rare to see in children. The study states that in the past century, there have only been 38 cases of CS in children and adolescents documented in English literature. And with this, only 5 of the cases have had reported concurrent OCD or OC symptoms, which is obsessive compulsive. During the period of 2022 to 2023, they were able to treat 2 children who had CS and OCD at their inpatient child psychiatric unit. The unit specializes in care from ages 6 to 12 years old, and its max capacity is 13 patients. The study states that both children exhibited additional psychiatric manifestations such as depression, catatonia, obsessive compulsive symptoms, persecutory delusions, reduced food intake, and suicidal ideation. With this, they also created a therapeutic approach for the 2 children, which involved gradual exposure to their parents, combined with antipsychotic and SSRI medications. Case 1 describes an 11-year-old male who they call Michael, who was admitted for compulsive behavior accompanied by persecutory delusions, hostility, and reduced food intake. 2 years prior to admission, when the family planned to relocate to a different town, is when Michael's psychiatric condition deteriorated. He began exhibiting new hygiene rituals, including prolonged showers with obsessive soap use, tissue use, and repetitive word and phrase rituals. Michael also became detached from his parents and siblings, displayed increasing aggression and hostility towards family and friends, and persistently avoided anything associated with the new town. No prior psychiatric concerns were in the family's history. Michael was initially suspected to have a pediatric autoimmune neuropsychiatric disorder associated with stereotypical infection, which is known as PANDAS. Michael received intravenous immunoglobulin (IVIG) without improvement. Before Michael's admission to the unit, his condition significantly worsened. He conducted escalating hygiene rituals and had complete disengagement from his family. Upon admission to the unit, Michael rejected his parents by refusing to see or speak with them, and the study states that he also exhibited multiple signs of emotional distress, such as crying, yelling, and threats of suicide upon encountering his parents. The study states that Michael expressed that his parents were imposters and that they were sent by the devil to harm himself and others, and that his real family was no longer there. The study states that Michael had a lot of testing done, including physical and neurological examinations, as well as comprehensive laboratory tests. These comprehensive laboratory tests included a toxicology screening, sleep-deprived EEG, and a cranial MRI, which all showed normal results. So while admitted, Michael received psychotherapy sessions twice a week, and his parents also participated in weekly parental training sessions as well. The psych unit has a behavior analyst who gradually exposed Michael to his family members' presence. The unit used a form of treatment that is based on the changing criteria design, and this means that after 3 successful sessions, the difficulty of the treatment would then be raised. The difficulty was determined based on the closeness to family members, and this was because Michael's family acted as his aversive triggers. Gradually, Michael was reintroduced to his family, such as his father, and was also exposed to stimuli related to his home and family, and this was shown through photos and videos. They also began pharmacology with Michael, and he was on the following medications: risperidone, metformin, and fluoxetine. With the combination of pharmacology, psychotherapy, and ERP, after 136 days in the unit, Michael's condition greatly improved. Testing was conducted again before his release, using the brief psychiatric rating scale for children and the retrospective modified overt aggression scale, and both of his scores were significantly lower than when he was originally admitted. The study states that Michael told his therapist, "I can be in my parents' presence since I moved to another dimension, which is a devil-free universe." However, Michael still mentions the previous dimension with the devil and maintained that his parents had been imposters sent by the devil. At discharge, Michael's diagnoses were OCD and CS. Case 2 refers to a 12-year-old female referred to as Dana. She was admitted for exhibiting abrupt changes in behavior, including oppositionality, persecutory delusions, catatonia, and OC symptoms. Dana had a normal school performance and participated in extracurricular activities. Although with this, her parents noticed early signs 2 months before her admission to the unit. Dana began to express feelings of sadness and loneliness. However, significant deterioration was present 3 weeks before her admission, when she began to be very hostile and aggressive towards her parents and strangers during a trip abroad. This led to Dana having to be placed in mechanical restraints at a general pediatric unit. Dana went under many of the same testing as Michael, such as physical and neurological examinations, lab tests, a cranial MRI, and a lumbar puncture, which all concluded normal results. Dana was initially diagnosed with acute psychosis and suspected of having autoimmune encephalopathy. Dana was treated with IVIG and olanzapine for up to 15 milligrams daily, which provided temporary improvement until she was discharged and refused to take her medication. Upon returning home in a state of severe agitation, Dana was admitted to a general pediatric unit where she was administered medication daily, which caused a sedative effect. Soon after was when she was transferred to the study's child psych inpatient unit. At the unit, Dana began exhibiting persecutory delusions involving her parents and the medical staff. She would state things like, "These are not my real parents. My parents were replaced by robots." The study states that Dana would also often repeat the phrase, "I wish you were all dead." She did not exhibit perceptual disturbances, but rather she displayed extreme verbal and physical aggressions towards her parents, the therapist, and even herself. It was also noticed that she displayed depressive OC and catatonic symptoms, such as immobility, negativism, echopraxia, and stereotypy. Dana's OC symptoms led to beliefs that physical actions would result in catastrophic consequences at home, which led her to initially refuse weekend home visits for the first 3 months during her admission. Dana had a trial period with different medications due to having no improvement on them, but ended up sticking to risperidone and escitalopram, which led to significant improvement. Dana's parents participated in weekly parental sessions, which included psychoeducation and symptom-focused strategies. Behavior analysts implemented gradual exposure therapy to Dana's parents, accompanied by 2 weekly supportive psychotherapy sessions. This is similar to the approach with Michael. Gradually, Dana's aggressive outbursts subsided and her insight into delusional thinking improved. Social interactions were increased, and Dana was allowed to spend weekends at home with her family. Some medication changes were conducted, and Dana's improvement was very apparent. After 171 days, Dana showed some suspicion by asking her parents, "Are you truly my parents?" After this, Dana improved on managing her delusions and was able to rely on and find comfort in her parents. Diagnoses at discharge included CS, catatonic features in partial remission, major depressive disorder in full remission, and OCD. I wanted to shed light on this study since the case study is based on 2 actual pediatric cases. The study shows in great depth how OCD can manifest differently in children and examples of how OCD symptoms can look in real life. It displays how a comorbidity can complicate a diagnosis. For example, both of the children were misdiagnosed in the beginning, while also providing information on how OCD is diagnosed in children and how the course of OCD can impact a child's life. Some best evidence-based treatment options for OCD in children include CBT, ERP, CT. Both ERP and CT fall under the cognitive behavioral therapy category. With this, CBT's category as a whole is recognized as the treatment of choice for children with OCD. The goal of these therapies is to help children face their fears, which are their obsessions, without doing a compulsion. CBT focuses on analyzing and understanding the cycle of the children's obsessions and compulsions, while ERP focuses on exposure and response prevention. Exposure is when the child is gradually introduced to the fear, and the response prevention is teaching the child to not perform the compulsion. Medications such as SRIs and SSRIs are also an effective form of treatment. SRIs are serotonin reuptake inhibitors, which affect one's serotonin levels by increasing and regulating them, while SSRIs fall under the category of SRIs, but the main difference between the two is that SSRIs target only serotonin by blocking the reabsorption of it into the brain, meaning that they don't actually increase the serotonin levels, but they help regulate the serotonin that is already there in the brain. But as we know, shown by the studies, there are also many other forms of medications that are beneficial to children with OCD that are not SRIs or SSRIs. Now I'd like to touch on some of the potential barriers to these forms of treatment, starting with CBT. Regarding CBT, it may be hard for children to grasp the concept of their own condition. It may be harder for a child to use treatment techniques if they do not fully understand the meaning behind their thoughts and compulsions. While with ERP, some barriers include high stress levels during treatment. If proper measures and pacing are not taken, it can actually jeopardize the treatment process by instilling more fear in the child. While with medication, some potential barriers include the side effects and the duration of time it takes to see improvement in condition, and some medications can take weeks to be at their full effect. Kind of going along with this is family-related barriers. So there's the potential for the family to not comply with certain forms of treatment, such as medications, and this can pose a barrier if other forms of treatment show no improvement in the child. This also applies to how the family helps the child and their treatment while at home. So the parents must be willing to accommodate their child in their treatment process and to make sure not to enable the child's compulsions. Parental burnout is also a potential barrier. If the parent becomes too stressed and no longer provides the support the child needs, it can interfere with the child's progression and worsen their condition. I'd also like to touch on some financial barriers. So many families may not be able to afford the cost for effective forms of treatment, especially those without any form of insurance. And same goes for geographical factors. So depending on where the family lives, there are potential barriers to the forms of treatment available and their accessibility. Many rural areas struggle with having enough providers. And that is the end of my presentation. Thank you, and here are my references.